Assalamualaikum and good evening to ladies and gentlemen. I am Dr. M Saifuddin, Associate Professor, Department of Endocrinology of Dhaka Medical College and Scientific Secretary, Bangladesh Endocrine Society. Today, I talk on very important topics, endocrine and metabolic care following cancer treatment. What are the challenges and options? Diabetic patient at high risk of developing severe cancer, potentially due to sheer risk factor between the two diseases of diabetes and cancer. Approximately 20% of people with cancer have concurrent diabetes. Cancer patients also have at increased risk of development of new onset diabetes or hyperglycemia, as well as worsening control of their pre-existing glycemia if the patient is diabetic. Hyperglycemia may attenuate the efficacy of chemotherapy medication in people with cancer, and diabetes is one of the poor prognostic factor. The person who are diagnosed as diabetes having developed any cancer event. Several anti-cancer medications are known to increase the risk of hyperglycemia even in individuals who are not known to be diabetic. Hyperglycemia during chemotherapy can occur in 10 to 30% of the people with cancer, although frequently transient, but in most of the times it usually remains persistent. And poor glycemic control can increase the risk of infection and hospitalization. This in turn may lead to treatment interruption as well as significant mortality and morbidity. And individuals with hyperglycemia have been shown to have higher rate of emergency hospital admission when the patient on cancer treatment if you compare with those who have no diabetes. There are different anti-cancer medications that are associated with hyperglycemia diabetes. Some targeted therapy, you can see the proportion or risk of development of the diabetes here. You can see some of the medications are associated even more than 50% chances of having development of diabetes. Some chemotherapy medication, hormone therapy, you can see here, alkylizing agent busulfan is associated with 66 to 67% higher chances of having diabetes or hyperglycemia. So a good number of anti-diabetic medication are associated with hyperglycemia. Immune checkpoint inhibitors are very defined in relation with the diabetes because they tend to destroy the beta cell with a mechanism similar to type 1 diabetes. They are associated with development of diabetes. So if the patient previously remained non-diabetic, after starting immune checkpoint inhibitor, a good number of patients has developed diabetes due to destruction of the beta cell, and the mechanism is associated with similar to type 1 diabetes. So there are some indication of use of glucocorticoid in oncology or malignancy patient like metastatic spinal cord compression, multiple myeloma, immunotherapy toxicity, superior vena-cava obstruction, graft versus host disease, brain metastasis, and supportive treatment of the chemotherapy. So in good number of malignant cases, you have to use glucocorticoids which are associated with the rise of blood sugar level, even the patient may be non-diabetic. So how to manage diabetes in a cancer patient? So as there is limitation of time, I have taken the recommendation from the British Diabetic Society in collaboration with UK Chemotherapy Board. So if you want to start an anti-cancer medication of glucocorticoid therapy in cancer patients who are not known to have diabetes, you should check the random blood sugar level. If it is less than 12, you should recheck the blood sugar level at each visit. If it is persistently less than 12, you don't need to be worried. But if blood sugar is between 12 to 20, in that case, you should check whether the patient has any hyperglycemic symptom or any ketonuria or ketonemia, where you have to think that the patient may develop diabetic ketoacidosis or hyperglycemic crisis. If the patient is not DQ or HONC, but blood sugar persistently more than 12, you can start gliclazide 40 mg per day, and you should keep monitoring of the blood sugar level. And you should increase the doses of the gliclazide up until blood sugar comes within target. When blood sugar is more than 20, in that case, you should assess whether the patient is DQ and HONC. In that case, you should transfer the patient to admission in the hospital under care for endocrinologist. If there is no DK and HONC, you should send the patient to endocrinologist to start anti-diabetic medication. If you think of starting immune checkpoint inhibitor in cancer patients who are not known to have diabetes, nearly similar thing. If blood sugar less than 12, you should not think of worry. If more than 12, you should start anti-diabetic medication. When it is more than 20, in that case, you should think and exclude hyperglycemic crisis. Also, when blood sugar is more than 20, you should check some antibody like GAT65 or anti-IHC antibody. Both are available in our country. We are commonly doing it in our clinical practice. As I've already mentioned, immune checkpoint inhibitor associated with similar mechanism of type 1 diabetes mellitus. If you plan to start systemic anti-cancer medication of glucocorticoid therapy in cancer patients who are on type 2 diabetes diagnosed on oral anti-diabetic medication, In such cases also, irrespective of the number of medication, you can add gliclazide 40 milligram per day. And I have already mentioned that the highest dose of the gliclazide is 320 milligram per day. In case of sustained release, 120 milligram per day. If blood sugar still remain uncontrolled, you should think of starting insulin regimen. If blood sugar is more than 20, in that case, you should exclude the diabetic ketoacidosis or any kind of hyperglycemic crisis. If the patient is already diabetic and known to be diabetic and on an anti-diabetic medication, especially insulin, you should adjust the doses of the insulin when you start anti-cancer medication. As I have already informed that a good number of anti-cancer medication are associated with increased risk of diabetes. Our target in a diabetic patient who are getting cancer treatment is 6 to 10 with a range of 6 to 12, and blood sugar monitoring is very important to prevent both hypo and hyperglycemia. Patient education is very important here, and relative and friends should make aware of the symptoms and signs of hypoglycemia, and we should provide ongoing professional guidance and support. At the end of life of a cancer patient with diabetes, strict glycemic control and blood pressure control is not mandatory. Simplification of regimen is needed. Intensity of lipid regimen can be relaxed. Overall comfort, prevention of distressing symptom, preservation of the quality, life and dignity of the patient is very important at the end of life. Also, a patient has every right to refuse the testing or treatment. You should not urge or put pressure on the patient or relative to start your treatment which you think is beneficial for the patient. And the decision process at the end of life always should involve the friends, family and caregiver. In patient with organ failure, preventing hypoglycemia is the greatest significance. In dying patient, discontinuation of all kind of anti-diabetic medication is mandatory, except in type 1 diabetes mellitus, while low-dose basal insulin you should think of to be continued. So there are some endocrine sequelae of cancer treatment. When you start different kinds of cancer treatment, chemotherapy medication, radiotherapy, or surgery, there are some endocrine sequelae you should be know of, irrespective of subspecialty you are dealing with. Hypopituitarism, when you do for pituitary surgery or radiotherapy, the patient may develop hypopituitarism. In all of the patient, in acutely ill patient, you should treat the patient as adrenal crisis. In chronically ill patient, you should start hormone replacement. First, you have to start glucocorticoid replacement, then thyroxine replacement. If you start thyroxine replacement at the earlier than glucocorticoid, there is a chance of adrenal crisis. Dose of glucocorticoid is 15 to 25 milligram per day, and minimum dose that is needed to maintain the well-being of the patient should be given. And this is the frequency and pattern of different anti-pituitary hormone deficiency after radiotherapy. You can see here. SIAD, that is syndrome of inappropriate anti-diabetic hormone syndrome. Vinca alkaloids, also a number of chemotherapeutic medication are associated with the SIAD. You should make the patient a bit fluid deprived of fluid restriction to 500 to 1000 ml per day. Oral urea or tolvaptans available in our country you're commonly using, you can think of using in diabetic patient with cancer who develop SIAD. Diabetes insipidus may be nephrogenic or central diabetes insipidus. If cranial diabetes insipidus, you should use desmopressin. In case of nephrogenic diabetes insipidus, you should use thiazide diuretics or NSAID like indomethacin. But you should always take help from an endocrinologist regarding how to differentiate between these two types of diabetes insipidus. In growth hormone deficiency, especially when the pituitary surgery has been done, in case of children, there is every chance of getting short stature. You should start growth hormone replacement available in our country also we are commonly using. But in adult, if you, after exclusion of other cause of weakness, if the patient persistently complains of fatigue, you should start low dose of growth hormone replacement. In hyperprolactinemia associated with a number of medication, drug treatment is indicated, not any kind of surgical option. Bromocriptine, cabergoline are both available in our country. Cabergoline is most potent. Once weekly dose, once or twice weekly dose is we are commonly using is longer acting and better tolerated is choice of our medication. In case of hypothyroidism, a number of medication are associated with thyroid dysfunction. You should start levothyroxine 1 to 2 microgram per kg per day, and if the patient have known ischemic heart disease, you should start a bit lower doses. After 4 to 6 weeks, you should do dose adjustment. In case of thyrotoxicosis, if the patient develop thyrotoxicosis after starting anti-cancer medication, you should start carbimazole 40 to 60 milligram per day. You should gradually taper the doses. Usually the treatment duration is 12 to 18 months. In case of adrenal dysfunction, patient may need glucocorticoid, also mineralocorticoid replacement. Glucocorticoid, commonly hydrocortisone, we are commonly using 15 to 25 milligram per day. Mineralocorticoid is also available in our country, 0.5 to 2 milligram per day, while it should be given in the morning. Gonadal dysfunction also very common when you start anti-cancer medication. An indication of testosterone replacement therapy patient with hypogonadism who is not interested in fertility, especially after fertility treatment. Patient is not interested in fertility, you should start gonadal hormone replacement, and patient is not able to achieve fertility. Hypocalcemia or malignancy sometimes itself associated with the hypocalcemic crisis, and in that case you should start IV calcium gluconate, 10% calcium gluconate, which is less irritant than chloride, and you should repeat the medication if the patient still remain symptomatic. Dyslipidemia also associated, both TZ and LDL may be associated with, you should start repeat drawing medication when the patient develop dyslipidemia. So take home message from my today's presentation: endocrine and metabolic disorder are common following cancer treatment. Cancer survivors need immediately structured follow-up in specialist surveillance center to improve care. Cancer patients should be treated with great care and empathy. An endocrinologist can play a vital role to provide endocrine and metabolic care following cancer treatment. Thanks and gratitude to Oncology Club to invite me here to deliver my presentation here, and thank you everyone for your kind attention. Thank you so much.